end-of-life issues was when I was asked by in Dallas to help him set up a hospice in Dallas. We were only the second hospice in the country. First one was in Connecticut, and then ours was the next one. And he did it through the Visiting Nurse Association in Dallas. And so I helped train most of the staff that were then coming, that were transitioning from being just, quote, just a nurse to being a hospice nurse, and how that changes your view of how you treat illness. Because as we know, sometimes illness is treated as a pathology that needs to be fought at all costs to the bitter end. This is one of the things that hospice is all about, that when the time comes that you realize that fighting is, or that the body is no longer responding to the treatments, and that it is actually starting to go into a terminal decline, that's the time that you need to go and switch to palliative care rather than to curative care. So I wanted to start by asking you a few questions here. And let me just get that up here for a moment. I wanted to ask you, what was your first experience with death? Was it a pet? Was it in a family? How was that for you? Can you either share or reflect on that? If you wish to share, that would be wonderful. And how old were you when you first,
I was 16 years old when my grandmother, my father's mother, died. And it was a pretty, I don't want to say scary, because they brought her body back and put it in our living room. And everybody stayed up all night long, and they were on the back porch singing and drinking and partying, like one big party. And Grandma was in the living room with the children who had to sleep on the floor. And it was a pretty scary thing to sleep in the same room with my grandma in that casket.
anyone else?
I was about 4, and I did not know my father's family very well. We just didn't have a lot of interaction with them. And I remember Mother had to, when I was about 3, Mother had been taking me upstairs to the bathroom and looking down through the banisters and seeing my grandmother in the casket. In my awareness that family came together at that time. I have very little other memories of that event, but and I think that it was when I went away to college and my parakeet, pretty boy, died. That was actual experience of loss of a loved one.
Okay, anyone else?
I was very close to my father's mother, my grandmother, and in fact I was named after her, and I was her pet. Just absolutely adored her, and she adored me. And then I remember one night in December, I could not sleep. I just kept having a feeling that something was not right. And when I woke up the next morning, I was told she had died in her sleep.
How old were you, Kathy?
10.
Oh.
10. And
we have a different attitude to death than most, I think. We tend to welcome it more than most people who believe in the Abrahamic path. And so the Frost family, as a general thing, used death as an excuse for another party. Just like you said, drinking on the back porch. Well, the children were involved. They weren't separated out from the rest of the party.
Well, that kind of speaks to the second part of here.
Yeah.
How did your families handle it? And talk about it. Did they have parties?
Came
what?
together.
Yeah, it came together. Were you included in the grieving process? Were you included in the ceremonies as a child, as a young child? Do you remember being excluded? Do you remember having questions that were not answered?
We were included, as I just said.
Oh, okay.
We had I was, because their parents, my parents' parents were so far away, I was not included in a lot of that, but death was just kind of a normal part of the process because we had a farm and we butchered animals to eat, and so death just seemed part of the normal process. And I remember the most surprising thing to me was a friend's dog was hit right in front of us as we waited for the bus one morning, and I was like, well, crap. And they were devastated, and we've been through that recently with one of Lars's friends whose family pet had died, and the children took a week from school because they were so devastated by the loss of their pet. No, they were not the same. But it's extraordinary to me to have that kind of relationship. And then I also wonder, with my British background, if I am, just kind of squelching things away. But I just view death as part of the normal process of life, not as something extraordinary.
Yeah. I think that the third part of that was what kind of messages about dying and leaving were you left with from all of this and other death experiences. That's really a very important part that plays into how we work when someone is very ill and in our family, and how we either avoid or embrace that death is coming, and that we facilitate it rather than to hinder it, to obstruct it, which is a very common thing in our society. Okay, so that's why I wanted to go through this little exercise with you, just as a sort of a start here. Now let me go into the main part of the presentation here. Okay, and this next part is sort of just for, there's been a major shift since World War II in where death occurs and how it's treated. Prior to World War II, first of all, we didn't have the kind of medications to keep people alive. If someone broke their hips, that was a one-way trip to the nursing home. You didn't have hip replacements, you didn't have the kind of surgical remedies that we have now. And in those days, 80% of people died at home. And now that is reversed. We have 80% of people dying in hospitals. Another 10% either die at home or in accidents and stuff, and only about 10% die at home. Completely changed around. And what that means is that when you die in a hospital, you're separated from your family. You're not dying. That's a major change here. What it also meant is that the physicians became this demigods. They're the experts. They know everything and you defer to them for judgments about what needs to happen. And then it's a pathology problem that the doctors wrestle with. They may be very idealistic when they first enter medical school, but by the time their third or fourth year comes around, they're totally involved in disease as a pathology process and how to solve this puzzle of the pathology. And it's not really that they're thinking in terms of the patient so much as they're thinking of the patient as the pathology. And that's part of the real problem here. So the end-of-life decisions then, as I said, become medical decisions. And of course, we have a curious attitude about death. One is that on the one hand, it's really totally sensationalized. I mean, if you look at the video games, the violent video games, there's a total disconnect between what is happening on the screen and any emotions. And, you get so many lives. If you screw up, you get another life to start all over again or to continue that kind of thing. But it really what it does, it desensitizes us to the reality of death. And that plus the fact that we are no longer having our family members, major older family members dying in the home, really separates us from death altogether, you know. And the medicalization, in a sense, hides that whole process behind closed doors in the hospital, okay? So very few of us, as a population, maybe you guys are different here, have any direct experience with dying. And so that creates then fear and avoidance of not wanting to talk about it. You know. Very few families can discuss it. If an older person, wants to discuss advanced directives with their younger children, what happens?
They run away.
Oh, you're gonna live forever, kind of
I don't wanna
myth.
talk about that, Mom.
And we don't, why? That's morbid. Why do you want to talk about that?
It's
You know?
never gonna happen.
My friends told me not to talk with Lars about it. I was like, really?
Yeah. So the impact, of course, on advanced directives is pretty bad. I mean, we only maybe 20% of the population have advanced directives. How many of you here have advanced directives? Ah, you guys are way good. I mean,
Some of us have committed our bodies to the old school
right. Same here.
when we're through with them.
Right. So basically, there's this superstition that if you talk about it, it's going to happen. You know, and that's that fear. And then a lot of older people, if they're being pressed to do it, have fears about someone's going to take over, someone's going to deny them care, someone's going to take over their finances. And remember this fear of death panels that was rampant for a while. With the Republicans talking about that, and so all of this kind of means that it's really hard for people to deal with advanced directives. But we need to know how they come into effect. That they only come into effect when you are in a terminal position. They don't come into effect when you just have an illness. No one can take away your medical power. You can take over medical power of attorney unless you have been declared to be in a terminal condition by at least one doctor. In some states, it's 2 doctors. So, and of course, we have this myth about CPR and about being able to come out of basically being dead, and then they work on you and they work on you, and then they open their eyes and they start smiling and everyone's happy and so forth, and live happily ever after. That's not what it is about. They did a study up at Morgantown, and they found out that only 14% survive CPR after age 65, and then only for about 48 hours. Okay? Only 14%. So, CPR, in most instances when you're talking about end of life kinds of decisions, should never be even considered as an option. I mean, think about it. When your body is worn out and you basically your system's worn out and you die, do you think by doing CPR you're going to revive all those organs that are already failing?
They oftentimes do a lot of damage to the body, broken ribs.
Exactly. And let me tell you a story. I was working for a kidney dialysis unit, and we had one elderly Baptist minister who, after about a year and a half of dialysis, said, "Hey, I don't want this anymore. I'm ready to die." Well, his wife wasn't ready for him to die. Okay, so she took him home, and he lived for another 10 or 12 days, and they were sitting and talking, and he just went out like a light. And she panicked and called 911. And of course they came and they did CPR, and they practically created rib salad in his chest, And he lived for another 24, 48 hours in really terrible pain, And she came to me afterwards and said, "Hanno, I just wish I'd let him die in my arms. I just wish I'd let that. The pain I inflicted upon that man, I just feel so bad." But she panicked. She couldn't accept the reality of what was happening. And this is why it's so important to prepare, to create that sacred space ahead of time. And of course, you know, if you put feeding tubes in to a dying person, then you have the horrendously hard decision of when to discontinue it. And that's really hard, because then you feel that you're killing that person by its own feeding tubes. You know. So we have this fight ethic, okay? The brave fight against cancer, the brave fight, and you fight right to the end. It's seen as a duty. And it's seen as a duty by the rest of your family usually. Okay? And everyone is co-opted into it. And so you submit to these extraordinarily damaging and quality of life reducing procedures. And of course, pain and discomfort is part of the struggle. And so when people say, well, how about, you know, hospice care? Oh, don't want to give up. And then of course it's oftentimes, you know, this is the physician perspective, that aggressive treatment will win the battle, you know, and interventions will pull the patient through a crisis, or will at least give you more time to live, but at usually vastly reduced quality of life. Okay, and so the physician also feels that he has to give hope to the family that we can pull this person through another crisis. You know? And so there's on the physician's part, there's strong resistance to stop the curative efforts. And cancer doctors are the worst in this. They're the very last ones to give up on and should commit people to hospice only when it's really obvious that that person is dying. So they usually only get about 5 days in hospice and then they die. The other part of that problem is that they're unwilling and unable, emotionally unable to communicate the bad news. Okay. I have a whole section when I used to do this training for doctors and hospice nurses about how to communicate bad news. Really, the only thing you need to say is, you know, it looks like from all the tests we're doing, your body is no longer responding to curative efforts. And so it would be best for us to switch to comfort care.
I'm in the quibble on semantics, as usual. It's perceived as bad news, but it's really unwelcome news.
Of course, yes, right. But I mean, no, it's bad news. It's bad news for the doctor. The doctors call it that.
Yeah.
I don't want to be the one to communicate the bad news. Nurse, why don't you tell her?
May I make a comment?
Yes, please.
A lot of you know Wally, and I kept Wally for 11 years and 11 months. And I think those of you who knew Wally knew that he had a smile on his face and we were happy. Okay? We came back at Thanksgiving after his physician not allowing me to drive to Charlottesville, and I'm a very independent lady. And Wally started going down, and he didn't want his physician help. Now, we have our advance directives. We know what everyone wants. And so I did not call his physician. As it turned out, his physical therapist, who had not promised my husband that he wouldn't call his physician, and by the way, Wally was a physician himself, he called him, and I'd forgotten to lock the garage door, which is the way the physical therapist came in now, and his physician had made house calls and knew I'd laid that door open for him, and I heard my cowbells go off, and his physician was there, and when I ran down from the kitchen to where Wally was, I heard his physician say, you just want to be home and be comfortable. And my husband said yes. We had already talked about all of this. And so his physician called in hospice, and we had hospice for less than 24 hours. But my husband passed away at the dining room table with his children, our 2 sons and their spouses, and our 8 grandchildren. And everyone kissed Grandpa goodbye, kissed Dad goodbye. And we waited for the funeral home to come.
That's the way to do it.
And I have listened, and I've had this experience because in my church I have started a widows group. And I have listened to the widows and those who have had their loved ones die in the hospital with all of these tubes, really ask themselves the question, could we have done more?
Could we have done it differently?
Well, differently might be.
Yeah.
At that point in time, they're very upset with medical staff. They just have all of these horrible feelings, and it didn't happen in our household.
Good. Yeah. That's really the object of what I'm promoting also. But in many instances, the emotional needs of the family are marginalized just by the institutional pressure to keep treatment going. Okay, that's part of it, you know. And of course, the fight ethic also goes, into the family frequently, where they are co-opted into this duty to support and to pray and to basically keep things going, and they encourage the patient to continue to keep on fighting this, and any discussion of preparing for dying is considered almost treasonous, so it keeps the family, but the problem here is that that's what keeps the family in denial, and it stifles what we call the anticipatory grief process. I mean, if you're ready by the time the person dies, you will have done most of the grieving, and you're ready, and it creates false hope, because this is it's distracting us really from the reality of what's going on right now, and this continued faith in medical technology, in spite of signs of terminal decline, there's that hope for the miracle that somehow God's going to come down and so everyone's enjoined to pray and to pray hard, and if you have any doubts and the rest of the family say, well, it'll be your fault if he dies, and I've seen it. Where members of the family are actually blamed for not, this is the conspiracy of silence, 80% of cancer patients die while still receiving treatments. That's outrageous. I'm sure that 90% of those people, it is clear at least 10, 15, or 30 days or longer before that the body is no longer responding, and that the body is being overwhelmed by this horrendous kind of treatment that is really destructive of tissue and of the immune system. So what it creates also, it's a negative self-worth, that we were not worthy enough in God's eyes to get a miracle, And so what happens oftentimes is that the patient dies alone without closure and without their loved ones. I'm talking about false hope here. It prevents this anticipatory grief, and it creates a lot of bottled up feelings. And what you often get then, especially when the whole family's been sort of co-opted into this religious fervor of praying for the miracle, is that you get a really complicated grief reaction afterwards. And I've dealt with that in And then, of course, you get this retrospective bargaining. If only I'd prayed harder, you know. If only, But there also is that sadness about having missed the opportunities to talk and share, which you had, or which your family had, right? Or to alleviate the pain and suffering. And the remorse and guilt for not having achieved closure. Because you were in denial, you never broached the subject of the finding emotional closure. Okay? And of course the depression over the failure and for faith and hope efforts, you know. And when basically one of the things that I suggest to people is assessing the patient and family's readiness to hear the bad news, you know, for people who are caretakers. What do you think is happening to you? I remember one time being in the presence, I was, you know, sort of a group that was following Elizabeth Kubler-Ross, and she went into this room where the person was dying, and she just sat down next to the patient, took her hand in her hand, and said, "So dear, tell me about it." That's what she said. And the woman opened up, talking about her feelings, and about the feelings of feeling like her family wasn't talking to her, and that she was feeling alone, and so on. You know. And it was very powerful. It was a real shock to me to sort of realize, you know, part of the program that I had in the Dallas area was a life enrichment program for older persons, which we had created because we had read a statistic that about 60 or 70% of nursing home residents had not had a visitor in over a year. You know, that basically were abandoned. You know. So basically, then you ask these questions: how do you see the medical treatment going? And usually, if you ask the patient, they know. By just asking an open-ended question about how do you think it's going with you, they know. And they will answer hopefully without that sense of duty of having to respond in what is the expected way, the duty way. What other experience have you had with others who've had the same experience, you know? And so you just get the family more open to discussing these kinds of things. And one of the other things that, you know, many families don't realize is they don't know anything about the disease process, about how certain diseases progress. Sherwin Nuland wrote this wonderful book, How We Die. It was a bestseller, won a prize for it. Very readable. And he sort of outlines, you know, especially what we call the terminal drop stage at the end. You know. And you talk about therapy options, and you talk about the degraded quality of life with the family and with the patient. You know, when you have an operation at that point, you have severe pain, usually debility afterwards. You may have cognitive impairment from the ether, from the anesthetic, you know. You may have major side effects from the chemotherapy and from the radiation. Feeling miserable, throwing up all the time, you know. When you're in that state, there's no time for achieving closure. There's no, you know, you just can't do that. The medical system bias is obviously towards continuing treatment. I mean, this unwillingness to give up, to concede defeat. That the doctors see it. The enemy is what? Death. You fight death, you know, and you win and you lose.
Well, I just think a lot of it has to do with money.
Well, yes and no. But I mean, there really is oftentimes a great commitment by the doctors to wanting to win that battle, and that's an ego battle, you know. And that's why they have such difficulty to concede defeat, and that's why they want the nurses to tell the family the bad news, you know.
My husband always felt like that resurrection medicine wasn't something to be practiced.
I like that. Resurrection medicine, I need that.
Write that down.
That's a
I
good
had a
one.
problem a couple of weeks ago. I went to hospital because I got chills from a very cold temperature in the room we were in. And in the middle of the night I couldn't breathe, so they rushed me off to hospital. And the next day I was fine, but I couldn't get out of that hospital. They said, you know, if you leave as you want to leave, and I was ready to leave, nobody will pay any of the hospital expenses, so you've got to stay. And they put me through one test after another, and you know, I'm walking down the hall to the next test, feeling fine, and they wouldn't let me leave. And finally I said, look, I'm leaving, whether you say so or not, I'm leaving. And
AMA,
I
right?
was stuck there 4 days for a total cost of $37,000. Okay?
Plus pharmaceuticals.
Yeah, that's
It's
what
the
many,
government paid mainly, but still. But I couldn't get away from the doctors.
yeah. Well, at that point, when oftentimes doctors may not have the same goals. You know, if there's a team involved,
Yeah.
and who does the family listen to? The one who offers the most hope, even though it may be false hope, right? So that's where you know you have, and of course part of the problem here oftentimes is that it's the child who's coming in from out of town at the last minute who wants everything done because they feel guilt. Part of it is feelings of guilt for not having been there during the battle. You know.
And even after that, feels like more should have been done before
Right.
they got.
Oh yeah. Oh yeah. So yeah, a lot of secrecy issues culturally in family, in dysfunctional families is worse. Oh, fight them go on. You know. But you know, as a family member and as a care member, team member, you need to probably talk to all the care team members and offer yourself to bring information back and forth between family and the doctors, you know. Maybe even coordinate a care conference and maybe assist in communicating the bad news. When you see that the doctors don't want to communicate the bad news, you say, okay, are you willing, are you ready for me to announce to the family that the curative efforts are no longer producing the results that we had hoped for?
Can I just say something? We were a team, and maybe that's one of the benefits of being a single parent, because he was very ill, and he'd been with me. We'd been on our own for 7 years before his father came along, and so it was the doctor and my son and I were a team. Once my son was back in the land of the living and was participating again, because he wasn't participating for a few weeks. Just but we were a team, and I was very assertive with our care. But he was also willing. Dr. Charbonnet and Dr. Swaji were both willing to be a part of that team and not hold out false hope.
Yeah,
Or,
good.
and especially, I think when you're an oncologist to children, that's such a tough job.
Yeah.
That
Well,
it's-
I think on the same point, I don't think there would have ever been a point where if they would have asked one of those questions like how is the treatment going or what's going on, I don't think there would have ever been a point where we would have said that.
yeah, no,
We always had optimism. We were going to have it, so there's that.
yeah.
Still,
I was much less optimistic about my father, who was in a hospital down the street, than I was about Marge's recovery.
Well, many times when you have many different specialists in on a case, they may all have different goals,
Right.
and so you need to coordinate the goals there. You know, but the other part that you, as someone, an advocate for a family that you know, or that if you're a caregiver yourself, need to make sure is that you remind the physicians to give the family time to achieve closure, not just to treat till the last minute. Because oftentimes, you know, when that person is in that chemo fog, you can't do that.
No, it's chemo brain.
Chemo brain, you know, chemo fog, whatever you like. So part of this might be having a care conference, and what I've done in care conferences that I've attended, I keep the checklist, and I give a copy of it to the doctor just to make sure. And if he skips or if he strays, I point to my copy and his copy, because I usually try to seat myself right next to him, and make sure that we talk about all of those issues. You know.
I had my paperwork done up and I did put the DMR on it,
Mm.
and they said, why do you want that? Because you're still too young. I said, well, that's what I want done. And he made me change it, or he asked me to change it.
This is not unusual. I mean, it goes against what they believe, and you know, this is just it's an imposition of their cultural value on your family or your personal values, and you just need to be really strong and say, you know, this is what I want. And if I'm in this position where I have died, I don't want to be revived. Yeah. That's basically it. I mean, they don't see it that way. They say, oh, it's a temporary stoppage of the heart. But if your heart is worn out because you've already worn out other systems that support the heart function, it's silly to try to get you back going. I mean, you can maybe get that heart pumping for another 48 hours. And after that, you know, it's going to be back to the same old stuff because they can't keep giving you those steroids to keep you going. You know.
How
So
can we get a copy of your checklist?
Or this checklist?
Yes.
Well, I tell you what, I can give you a paper copy of this whole
That would be
thing.
great.
Or if you could send it to me, Hanno, then I can
Okay.
pass it out to everybody.
Sure.
But some of what you're talking about is the difference between resuscitation when the whole body is really not functioning, or something sudden happen
Sure.
where other systems are still doing well
When
and it's just
for electrocution, for a sudden blow to the chest, which stops the heart, or from arrhythmias like tachycardia, that's when you use CPR. That's what it's for.
right.
You know, to restart the heart. The rest of the body is healthy, but the heart has accidentally stopped
Right.
beating, and that's what it's for. But not when your rest of your system is worn out. That's the major difference here. Okay.
Remember when Tom Kendrick was in gym one
Right.
morning working and his
Heart stopped.
one of his arteries tore.
Yeah.
And they just took him in and mended it, and he got right back up and
Right.
began living again.
Sure, and that's different.
Productive.
And this is what, when the body is healthy, that's what CPR is for. The body is worn out and ready to give up and no longer supporting. I mean, it's usually the kidneys and liver functions and digestive functions, you know, that start to go, and then you accumulate toxins in your system, and that means that the heart can't function much. Okay. What's the prognosis? For planning purposes, and this is what you ask. What are you expecting, or what does your inner voice tell you? This is kind of what you ask the patient too. And what I'm asking the doctor here is what are you expecting to achieve with continued treatment? And of course, when you're answering a patient's or the family's question, you need to avoid precise answers. Well, I think you have 3.5 more days to live. Do you you don't do that. Well, in situations like this, people can live as long as 6 months or a year, or it could happen in the next 2 weeks. So, best to get ready. Suggesting getting the affairs in order. Palliative care options, of course. Usually in hospital palliative care, there's relatively few hospitals that do really good palliative care. So you need to either have in-home hospice care, or there's Charleston, we have one in Lewisburg now that are residential hospice cares. And many families are unprepared to do it in the home, because you really need to have space, you need to have accommodations that allow you to move the person around, But in-home hospice care has many emotional advantages.
When Al Yeomans, who was a very active member of this congregation, was dying, he stayed home with support from this congregation, especially Evelyn.
Right.
And so,
Yeah, if you can arrange to have a rotating group of caregivers, that's wonderful. And I think you guys did a good job with that. And who's going to be the principal caregiver? And when there is a principal caregiver, there needs to be some kind of arrangement for respite care for that principal caregiver, because it's very stressful. And who's willing to contribute financially for the hired help? It may need to come in also. So that needs to be a family decision. The home needs to be ready for all of this. Family needs to have gap-free coverage, and regular scheduled respite periods. Hospice care it needs to be concept with skilled care needs, and then that will then allow for the shift to the focus on inner healing. Okay, we're talking about stopping curative efforts, but the healing then can occur. Does that make sense? Okay. So that's when we shift the focus from curative to comfort care, and then the patient's illness is no longer the primary focus. And you're really wanting to create this peaceful zone of rest and comfort and inner healing, which has to be done with really good pain management. Okay. Pain and suffering is often really a function of fear and anxiety. We know that the more fear and anxiety you have about pain, the more intense the pain tends to be. Okay. Stephen Levine's book, Working with Pain, is in that chapter on Who Dies, an Investigation of Conscious Living and Dying, is an excellent resource on that. And reading aloud from that book or from scripture, using guided imagery, or music for comfort and reducing the pain, gentle massage, reassuring touch, basically all of those things that allow the person that he's not the pathology anymore, that it's a real person there, that he's loved and cared for. Okay. And basically, as I say here, the focus is on the person's need for touch and expressions of love and reassurance. Yeah. And the support for their patient's struggle to accept the approach of death, as well as each other's struggle to come to terms with the anticipatory grief process here, and supporting each other through that. One of the things that really helps here is a life review process. And this can be done sometimes by grandchildren, being there and asking the grandparent, tell me about your growing up. Tell me how it was during the Depression, or tell me about the time when you met Grandpa or something like that. Allowing them to review really nice, positive experiences, you know, that they can sort of relate to then as another time when things weren't painful. Does that make sense? And this kind of reminiscence as a life review can be accompanied by bringing out photo albums and having the person explain what happened here and there and so forth. So basically, you're reviewing the good times as well as the hard times maybe, and how you conquered the hard times, giving the person credit for having overcome hard knocks and failures and so on, you know. That's part of this process of creating sacred space. Because this is where the person now is sort of like totally turning away from just the disease process now to looking at this inner healing idea. And what partly happens here also is that you're really, in a sense, also the family is preparing itself for the death of a family member, and encouraging them to express their fears and concerns, and overcoming that reluctance to talk about death. You know, explaining the stages of grief. I'm constantly amazed by how many people don't know about stages of grief, including the anger at the doctors, the anger at God, you know, that for not saving him. Why are you letting this good person die, you know? And supporting each other for in their grief process. You know? As I said, the anger is oftentimes a large part of this. Yeah. And sometimes the fear of punishment, which can be part of a dying person, if they really believe that they've not been a good person, that they're going to be punished by God. And this, you know, maybe an inability to forgive themselves at that stage, and helping them through that is really an important point, because that's one of the things that really increases the fear of death. You feel that, oh my gosh, I can't die because God's going to be mad at me, God's going to punish me.
I'm going to hell.
Hmm?
I'm going to hell.
Yeah, going to hell. Sure, that's the extreme form of it. So this is the whole idea here. It increases the anxiety, and it can magnify the physical pain. Regret over things not said, unexpressed feelings of love and appreciation. This is the time to do those things. You know. And so the goal here is to move from the psychic pain to self-acceptance and teaching the art of letting go. And again, being able to read maybe from Stephen Levine's book, identifying with past successes and mistakes as false images of itself. I mean, both ego successes as well as mistakes, in a sense, are false images. You know? That really what we're looking at is going with the now. True self as separate from ego beliefs about who we are. There's only the now and what we can do to achieve harmony now with the people in our family. That's the task of this sacred space. Focusing on achieving closure and getting ready for the transition. And the people may be, at this point, be drifting in and out of consciousness. And the idea is to continue expressions of love and ask the person if there's anything more that they wish to say.
And what may happen here is that people may have end-of-life visions. Okay? And these are harbingers of impending transition. This is where they have one foot in this reality and another foot in the other dimension. Okay? And they're shifting back and forth. Some of you may not believe this, but definitely there's a lot of literature on this that talks about this. And what I'm suggesting here is, rather than when a person is talking to someone in the corner up here, and rather than saying, "There's nobody there, Mom, what are you doing?" Saying, "Tell me, what are they saying? What's happening?" And engage them, because what can happen is that it becomes a spiritual nurturance for you when that happens. To know that they are going to be welcomed by other people on the other side.
We're waiting for you.
We're waiting for you. Yeah. And so to normalize it for the dying person, and to encourage them to share it with the people who are at bedside. I've talked to a lot of hospice nurses. There is not a one of them that hasn't had that experience with the dying patient. I've had one nun one time in one of my workshops, and when she first walked in, I realized she had this incredible aura around her, and she just radiated serenity and peace. And she had literally hundreds of experiences like that, because she knew how to facilitate this kind of sacred space. It was just beautiful. So, when the time comes, you need to let people know what's likely to happen. And I've got a clip here I wanted to play for you. The goal here is to tell people what to expect in this terminal drop stage, because there is this one after another of the major organs are going to start to fail, and which means that food and liquids can no longer be processed, and so giving food and liquid at that point is contraindicated, because what it does, it creates toxins and physical pain, and also cognitive impairment. Okay, which means that then they can't really talk as clearly anymore. So you really, at that point, you stop nutrition. And when you realize that the body is producing little or no urine anymore, you stop hydration. What you may want to do is just wet their lips and put some wetness right under their nose and so on, but you really have to stop that. I had a young man who came from out of town and found out that his father was didn't know what a terminal drop stage was, but saw that his brother wasn't feeding his father, and so fixed him a big steak and potatoes meal, and of course the guy died in terrible agony the next afternoon. All that buildup of the toxin. When your body can't process that stuff anymore, it just builds up toxins in the system. Okay. So
what I wanted to do was.
Let me start this again. This is from a program that was done on PBS on end of life, and that's what's his name on the left, the great interviewer. But you'll see. Anyway, this is the very young hospice doctor, and just listen to the wisdom of this guy. It's just amazing. So let me start this.
What I wanted to do was a couple of things. One is just to answer questions, and then talk with you all about what to expect over the next day or week or so, and see where we go. Let's start with the IV fluids, Nancy. I look at it really as an intervention we started with a clear purpose, which was to see if it would make her more awake. And I think it did for a little while. I'm not not sure it's doing it now. The other thing that Mrs. Kerr was always very clear to me was that when it was time for her to die, that we don't prolong it. And certainly intravenous fluids will prolong it, but they won't make her quality better. I think that it's going to cause more discomfort than comfort now. And it's one less bag to have at the bedside.
It worked fine, it didn't work
Right.
stuff.
Was there a weekend?
Yeah.
Right. It's still hard to believe.
Sometimes I don't know if we should be working to get her more alert or just letting her, I mean, you can, get her to open her eyes, but I don't know if that's helping her or helping her mind, or we should.
Everybody's different. Just when she wakes up and is more alert with you, if she seems to enjoy that, do it. She may not respond, but I'm sure she hears you. So, conversations that you wouldn't want to have in front of her, don't. Okay? Always believe that she's hearing you. Normal things, not to worry about which happen. Okay? Very normal things. The amount of urine she makes will start to drop off. Her breathing pattern will change. And first, what's happening now is her breathing may start to get a little faster and shallower. Okay? And then it may start to get irregular. And then what sounds like gasps. Okay? That's not air hunger. Okay? I want to be very, very clear. Okay? It's not that she's suffocating, that's just normal. What morphine does, and drugs like morphine, is it prevents the body from sensing that your chest is moving really quickly, from sensing that there's not enough oxygen. So it's really important to realize that even though her breathing may get faster, it may get slower, or she might have long pauses where for you or I holding our breath would be very uncomfortable, she's not going to perceive that as being uncomfortable.
She'll be scared.
She won't be scared, okay. She won't know what's happening, and she won't be short of breath. The other sign, one here, which we need to talk about, is a gurgling sound that you might hear in the last day or so before death. Okay. What happens is when you start to lose the ability to swallow or to clear secretions in your mouth, there's a very thin layer of fluid that builds up over the vocal cords and the trachea, the breathing pipe. Okay. And as air moves up and through that, it sounds all the world like somebody could be suffocating or choking. It can be very distressing to listen to. Okay? It's really important to realize that all that is air moving through a thin layer of fluid. Okay? It's not as if she's suffocating. It's not as if she's choking. It's just a really lousy, terrible noise which is made by something very simple. A couple hard questions. Is she ready?
Yes.
Okay. And you have everybody who said goodbye has had a chance to say goodbye. Last practical thing is what happens when she dies. Don't call an ambulance. Don't call 911. Don't panic. Okay. We've talked a little bit about, what's going to happen. She'll probably take a last breath, a couple shallow breaths, and that will be it. Okay. And after that, there's no rush. All you need to do is call the hospice. Okay. Call the hospice. Just let them know that she died. They'll send a nurse.
Just tell me.
It's just, there's no right way to do this. Okay? There's absolutely no right way. It's really who you are and how I want to do.
I don't know what's going to do tomorrow, we just do it. Whatever.
It's an experience as a family.
Yeah.
It's a new experience as a family. One of the instruction he gave us is very sensitive testimonies.
That gurgling, I think I've heard it called the death rattle.
It's called a death rattle, right?
And
Yeah, for one more thing, for us who are survivors, our tears are the sign of our healing has begun, our healing.
Did you hear that? She says our tears are a sign that our healing has begun. So it's like when you're surviving a death like this. But, this family had done their anticipatory grieving. They're prepared. They've created that sacred space. That's the idea here. So, that's the end of my, do you have any questions?
If